healthcare quality. The agenda this evening in healthcare quality basics are history of healthcare quality, definitions of quality, key dimensions of quality of care. Fourth, the concept of value. Five, the main difference between quality assurance and the total quality management, and the two types of customers, the Nabesian diagram, and lastly, the integrated delivery system and roles of quality manager.
Can you please,
Yes,
the screen is not moving. Can you move this slide? Can you move the slide?
okay, Doc. Hold on.
Yes, it's okay now.
It's okay now? Okay, thank you. So I will continue. Before I go into the explanation, I always like for us to set our intention in studying healthcare quality. The intention is to prevent harm or to prevent harm to anyone who might be a patient, Muslim or not Muslim. We learn quality so that we can apply it in healthcare to prevent any harm that might happen to who is ill or in a medical condition or who is a patient. Okay, so we'll now talk about the purpose of quality. Why are we applying quality? Because we have a goal in applying quality, and that is to provide healthcare services. And those services should achieve reduced risk and better patient outcomes. The patient wants to be taken care under the medical institution with better outcomes. And all of this should be applied with low costs, or what is called optimization of resources. We use resources wisely, reduce costs as much as possible, and at the same time, the patient who is in the hospital should not be exposed to any additional harm, any injury, or any infection. Like, for example, they walk, sleep, fall, and end up with a fracture in the hip, or they get an infection because of their stay in the hospital. It's an additional infection. Okay, so now what is the history of healthcare quality? There was a scholar named Deming and his colleague Schuhart. They developed a cycle called the PDCA and PDSA cycles. They said that this cycle is what we will use, or the steps that are considered fundamental when we want to make any improvement in any project or for continuous health quality improvement. The meaning of continuous quality improvement is that we aim to create ongoing improvement. They named it PDCA, which stands for P, plan, B, do, C, check, A, act, or instead of check, it becomes study. We will study this in detail later. The plan, do, study, and act. Demi also mentioned something interesting. He said that 94% of the problems in business are system driven and only 6% are people driven. They discovered that 94%, which is a very high percentage of the problems that happen in business or processes, are caused by the system. The system in place is the problem, not the fault of the individual. So, we shouldn't engage in blaming and punishing the people in our system. Instead, search and investigate the root causes. I will find that the problem lies in me, not having a good system. So, for example, if a nurse made a mistake and the patient was harmed accidentally, and I punished the nurse, saying to her, "You are negligent, you don't focus, you're not alert to your work," and so on. I punished her, deducted her pay, and let her go. Yet, in the end, when I investigate and search for the root of the problem, I find that the nurse, while administering the medication, found that the two drug boxes had the same shape, the same external appearance, and they were placed next to each other. For instance, Depovit and dexamethasone. The nurse was supposed to give the patient dexamethasone, but by mistake, she gave them Depovit. She administered intravenously, even though it's not meant to be administered intravenously. The two medications look identical in external packaging by the same company, and they were placed next to each other because they both start with the letter B and are very close to each other. I punished the nurse, but the fault is in the system. She did not create a separation for drugs that are similar in appearance and name. And I didn't put a label on the two drugs to alert the person or the individual in the team. I would have said, pay attention and focus on what you are dispensing because there is something similar in name or appearance. So only 6% of the time is the issue related to people. It could be reckless behavior or the people is irresponsible, intentionally makes a mistake or ignores the task to make their work easier. But the percentage of such cases is small. Then came Joseph Juran, another scholar in quality, who said that to achieve any improvement or any quality management, which is the quality management cycle, it goes through three fundamental stages. And the three stages is called the Juran trilogy. The Juran trilogy that he described starts with if you want to apply quality, the first thing is that you'll plan for quality, which is the quality planning. The second stage is to ensure order control during the control stage. And the third stage is that if variations occurs, and the word variation means that a problem has occurred, or it means that a product was produced that does not meet the specifications you originally set for the production. Then here, you move to quality and make improvements to the thing where the problem occurred. So how this process work? So he said there's a stage where you first identify the customer and what exactly they need. For example, I have a client who needs a medical service, or is it a customer who wants to buy a phone or wants to buy something? What exactly do they want? I need to figure out the client's needs, right? So do you want this furniture in a specific color, design, or type of wood? Do you want a modern design or a classic design? You need to know the requirements language, meaning to set the steps for the plan I will follow to implement the plan that will result in a product meeting the client's specifications. It's like a process. Then I begin to apply and establish the plan that I will implement to produce a product matching the client's needs. The second step is the quality control stage. And in quality control, here you do what is called the transfer process to operations, meaning that I now begin to working in real life operations with my focus on the process as it progresses. At this stage, I work on conducting an initial analysis. Initial analysis means I am continuously analyzing the process standards and ensuring that everything is fine. If any variation occurs, or if the process deviates and the product doesn't turn out as I wanted, and there's a variation, then I intervene to conduct a quality improvement process. Here, I will optimize. In this case, we perform the intensive analysis, meaning I conduct a root analysis to understand the reasons that led to this process deviation and why the product did not meet the specifications. Okay, so this is the Durand trilogy, starting with quality planning, quality control, and improvement. He further said to return to continue working on quality control because this stage is ongoing and continuous because it's necessary for the process to be sustained. Doc, I'm so nervous, Doc. Okay,
Yes,
the
great.
next,
Great, Annabella, complete.
thank you. The next scholar's name is Crosby. Crosby's work focuses on the principles of zero defects. In Crosby's approach, he has a concept that says, I want to apply a system where I have zero errors, not even one mistake. He defined the response to the requirements or the specifications that I set for producing a product. I want to produce a product to be fully compliant with the specifications that is conformance to requirements. I want to have zero errors, reflecting that defect prevention is preferable. The standard of quality is always zero defects, means there are no flaws or failures, and quality is measured on the basis of price. So what's next? If I will ask someone and say, what does it mean to apply quality? They will say, do it right from the beginning. If you ask someone, what does quality mean? They will say, it means do it right from the start. That is, from the beginning, follow the right foundations so that you don't end up, after building the structure, tearing it all down, destroying it entirely, and spending a lot of money on it. Doing the right first time is done. Conformance to relevant requirements or standards, satisfying the needs and the expectations of customers. Freedom of deficiencies, which means less costly because the presence of deficiencies will cause customer dissatisfaction, which will need to be reduced or eliminated through correction. So, this is what the standards mean. By the way, so no one comes and says, I'm going to memorize something. The word memorize is not in our vocabulary at all. So the word memorize, don't ever think about it. We only understand by heart. There is no memorization here. We are all adults, and besides, we already study smart, not the hard way. We study smartly with intelligence, not by hard way, memorizing, holding the book, and sitting for hours just to memorize. No, this is not how it works. All we do is attend the lecture, understand it, and that's it. Nothing more is required of you. The definitions of quality in healthcare by the JCI or the Joint Commission defines quality as the optimal achievement of therapeutic benefit and avoidance of risk and minimization of harm. The optimal achievement or realization of medical benefit while at the same time avoiding any harm that could affect the patient. Another definition of quality in healthcare is the degree of conformity with accepted principles and practices or standards, the degree of attainment of acceptable outcomes. Commit to applying the program or standard, and all of these will achieve to realize the expected outcome, meaning to work smarter, not harder, while making appropriate use of resources. So, the next topic we will discuss is the key dimension of care, quality of care. The meaning is the umbrella that includes the basic directions of quality, so that I can say that the service I am providing truly fulfills these key conditions. The first thing is, given the current state of knowledge, I cannot give my client a product that doesn't meet the specifications they set. For example, if they come to buy a bedroom set, I cannot say, no, buy a dining set instead. This is where I talk about one, appropriateness, to which the care and services provided are relevant to the individual's clinical needs given. An examples in healthcare. A patient comes to me needing a medical service, for example, to check or treat an issue in internal medicine. I cannot send them to the dental department and say, come, take a look at the dental department or our dermatology department, where you can do peeling sessions or teeth whitening. No, I will give them the service they need and focus on their specific medical issue. This means I will provide the service. That's the meaning of appropriateness, the degree to which the care and services provided are relevant to the individual's clinical needs given the current state of knowledge. Number two, availability. There is accessibility means ensuring that the patient can easily access the service and the care they are coming for. The healthcare organization should not be disorganized, chaotic, or without proper signs and directions, confusing the patient who is trying to find out which department to go to, how to get there, and where to walk. No, the service must always be accessible and easy to obtain. Number three, competency. And here, I am talking about the competence of the clinical staff, meaning the doctors. We need to ensure that they have a high degree of competence to achieve patient satisfaction. In the past, the focus was only on clinical outcomes, and patient satisfaction was not given much importance. But now, patient satisfaction and patient experience have become a high priority. The importance of patient satisfaction is no less than achieving clinical outcomes. The psychological state of the patient and their satisfaction with the service is extremely important and is as significant as clinical outcomes. We also ensure competence by conducting something called peer reviews for all the doctors we have. This means we compare them with peers in the same specialty, analyzing how they handle cases that come to them with similar clinical statuses. Next, continuity. This means that the medical service should be continuous, ongoing, and not interrupted. It is not that just because the patient was discharged from my care, all our contact is cut off. No. Continuous service means even after discharge, the staff we have may need to conduct follow-ups to monitor any X-ray results or if they need to perform any lab investigations or anything else. Or if there is a follow-up for anything, the service should remain continuous. Next, number 5, effectiveness. The degree to which care achieves the desired outcomes. Effectiveness focuses on the outcome, which is that the service I provide to the patient practically, in reality, results in good clinical outcomes. For example, the patient comes to me complaining or having problems or complaining of pain and leaves as a patient with pain relief. Their pain is gone and the problems they had are resolved. This means I have achieved the desired outcome, which is achieving the effect. Next, efficacy. Efficacy always refers to the capacity or capability of care to produce the desired outcomes. This means, theoretically, I talk about my service saying that I am capable of performing. For example, open heart surgery efficiently because I have highly skilled staff. I have the necessary facilities, the operating room, the complete requirements, and all the medications, equipment, and everything else needed to perform this operation. So here, I'm saying that I have a potential for open heart surgery. It means I am capable of performing this operation. Have I performed it yet? No, not yet. If I perform it and it delivers good outcomes, that's called effectiveness. But I am talking theoretically. I'm referring to efficacy relates to capacity or capability, means my ability to provide a service. And this service should achieve the desired outcome. Or when I talk about applying something, for example, clinical research or scientific studies that prove the effectiveness of a certain medication, then when I say I will use this medication based on what scientific studies confirmed, this also refers to efficacy. Another example related to is when I say I will give you a flu vaccine. And after giving the flu vaccine, I want to see the results. Here, I measure what? I measure the action. Okay, number 7 is efficiency. Efficiency refers to resources. In efficiency, it is important that the service I provide to the patient is reasonable. I cannot provide a service and tell them your cost is 1 million reals just because I put them in a VIP room, gave them specialized staff, and provided unnecessary extras. No, it must still be something reasonable and efficient. So, optimal use of resources. I cannot give medications they don't need, inject them with many unnecessary medications, or add unnecessary lab tests, or extend their hospital stay unnecessarily. For example, keeping a patient for a week or two in the hospital when their condition doesn't require more than a day or two is just waste. This is a waste of resources. The point is to be logical and efficient in resource use because efficiency means the optimum utilization of resources to produce the desired outcomes. Next is prevention. The degree to which care promote health and prevent disease. The idea is to ensure that I keep the patient in the hospital only as long as necessary for treatment to promote health and ensure they don't acquire any additional infectious during their hospital stay. At the same time, I focus on promoting health through awareness campaigns about personal hygiene, healthy eating, the importance of exercise, and a balanced diet. These efforts aim to promote well-being and prevent diseases. For example, for people who are pre-diabetic or at risk of any illness, or for older adults, we can implement awareness program to reduce disease risk. Next is respect and caring. This focuses on the relationship between you and the patient. Is the patient involved with you in their plan of care? Do they understand their treatment plan, their illness, and the dimensions of their care? Are they aware of their medical condition and the necessary treatments? Or are they uninformed? In respected caring, I focus on ensuring the patient is actively involved with you, that you respond to their needs, and that every step you take includes them in the process. Next is safety. Safety here applies to all healthcare organizations, including the patients, visitors, and staff in the environment. The infrastructure itself, especially for healthcare, should be safe. There should not be exposed wires leading to electrical accidents. There should not be wet floors where anyone walking might slip, fall, and end up with a fracture. Hand hygiene compliance. We emphasize hand hygiene compliance for health workers, even those who are not doctors. Hand hygiene is also important to prevent or reduce infections. Next is timeliness. The timeliness is also very important to provide the service at the appropriate time. For example, if the patient arrives with an injury and needs urgent treatment based on the protocol for the condition, if you delay and give the treatment after 10 hours or something, you are worsening their condition and making it worse. Therefore, the timeline is part of the main definition of quality, meaning that service should be delivered promptly. The main definition of quality, meaning that the service you are providing, in order to be under quality or the umbrella of quality, must go through or comply with the key dimension of quality aspects. Quality of care means the basic directions that, when we measure the quality of medical service, we look at the first thing is measurable, meaning that the service I am providing can be measured by comparing it to the standard of care, comparing it to the pros and cons, and seeing whether the steps taken are consistent with our policies and procedures or not. Compare it to the clinical practice guideline, the treatment protocol, and whether the steps taken align with it or not. Next is appreciative quality. And the meaning of appreciative here is that I want to see if the patient process done for this patient was correct or not, or if there were any variations. In this quality, I focus on things like peer review, and peer review means that I bring a peer to the doctor to review the cases they are working on to ensure competency and efficiency. And lastly, perceptive quality. Here, focuses on satisfaction, meaning the patient themselves should be satisfied. Did you achieve their expectations? And was the patient truly satisfied or not? All right. So up to this point, things are clear. So next, what is a quality management? When I put a system to implement, I have to collect information and do analysis, set plans on how to implement in order to achieve. By how? What does it mean? A quality management means a planned, systematic, and organization-wide approach to monitor, analyze, and improve organizational performance, thereby continually improving the quality of care and services provided. It helps me in improving overall performance and the clinical operations, working on performance and continuous performance improvement, and continuous enhancement for all the healthcare services we provide and all the processes we deliver. And of course, this is organized work and is done systematically. We don't just say we will do improvement at the level of all the organizations at once. No, we proceed step by step and process by process. All right? So for the total quality management, to achieve it, I must have a leadership commitment. Let's take this together from the first lecture. The rule is that implementing anything in quality without leadership commitment has no value and will not yield any result at all. So, what is leadership commitment? The leadership commitment means the leaders and heads of departments, including the general manager, the medical director, the CNO, the CEO, and all these managers must be committed with you in the team or organization, meaning they must be involved. They must be with you, attending meetings with you, present, knowing what is happening and what is being done. They should support you and provide the resources you might need. They should provide support to all the organization's employees, ensuring they are involved, working with you, and participating in development to have a continuous improvement. So, to achieve that, I must conduct assessments for all the processes and evaluate the current situation very well to achieve these goals. And there must be focus. Of course, we focus on consumers and their expectations. Okay. The continuous quality the continuous quality improvement process in order to achieve this. The first thing we said is commitment, which is leadership commitment. Why is leadership commitment is very important? Because the leaders are the ones who will set the strategic vision, mission, and strategic goals. Our strategic objectives, which are the strategic plan, our strategic plan that will be the main driving force that I will follow. Based on it, we will begin our steps in change and improvement according to our strategic plan. So we start to map the processes we have, understand the steps of each process to work on improving it, and perform reviews, which is a cycle for the continuous improvement. Now let's take together the difference between quality assurance and total quality management. The quality assurance, it was first called the old quality or quality in the past, and activities related to external structure or changing the building's appearance, while the total quality management activity is cross-departmental according to patient flow, meaning that any improvement we make is done as a team. And this team is multidisciplinary because any activity we perform or anything the patient goes through is all interconnected. For example, if we want to improve the laboratory department, we will form a team, right? From all the departments, including department heads or representatives from each department, it will be beneficial as all the departments are interconnected. But in the past, the activity was department specific. For instance, if we wanted to make improvements in the lab, we hold a meeting and figure out how to improve the situation only in the lab. Unlike now, it is easier because we include someone from management to provide resources, involve someone from nursing to address any issues with sample delivery, delays, or anything else. So now, we find that indeed, the department must form a cross-departmental team because all the departments are truly interconnected. Additionally, nowadays, we approve both clinical and non-clinical processes, unlike before, when the focus was on the external structure. In total quality management, we work on continuous improvement before any problem even occurs. But in quality, we would not take action until there was a problem. Only after a problem arose and people reported it or filed a lawsuit against us would we start investigating what caused the issue and solve it. In the past, any problem that happened or any mistake made by someone, we would immediately ask, who did this? Who? We'd ask, who made this mistake? Come quickly. Here's the scapegoat. We caught him and we will punish him, fire him, and so on. But now we have said that errors are 94% due to the system. So when I ask, I will never ask who, rather to ask what exactly happened. So we can identify the issues in our system and resolve them. Now we focus on the patient care processes and patient care outcomes. We also focus on both, unlike before when we only focus on the patient and the caregiver. The patient and the caregivers are the healthcare providers. But now we also focus on the patient care outcomes and the medical service itself, whether the desired outcomes were achieved or not, and whether the customer is satisfied or not. So, who are they? Who are these customers? We have two types of customers, the internal and the external customers. The employees within the organization, including the owner of the establishment, and all the employees, such as doctors, physicians, nurses, housekeeping staff, receptionists, and everyone working inside the organization. These are the internal customers. The external customers, on the other hand, are those outside the organization, such as patients, families, peers, insurance companies, providers from whom I purchase medications or medical supplies. All of these are considered external customers. Internal being within the organization and external being those outside the organization, but with whom I interact, of course, to achieve the organizational goals. For example, if your organization is a hospital, the services you provide to them, whether related to medical care, the nature of work, or everything else, need to be capable of enabling them to provide a service that satisfies the last customer, completely like patients. A customer is one who receives goods or services. Customer satisfaction is viewed in healthcare as an essential component of success in delivering quality because the value for the consumer, this includes the price of care, interpersonal interactions, and the quality of the service received. Okay, 100% customer. The types of customers here, as you can see, we have the internal customers and external customers. Internal, those performing work within the organization that includes all working staff, medical staff, non-medical staff, and administrative staff and human resource, while external, those outside the organization. That includes the patients, our families and friends of patients, the payers, reviewers, the regulators and accrediting agents, as well as community. Okay, 100% customer focus is equal to customer satisfaction. With 100% quality, service and reliability means equal to satisfaction. Our focus on quality is on the system and the staff we have and what the customers specifically need in the services, and we work to achieve the customer expectations. We continuously improve the customer experience by valuing their opinions. So, what is the difference between a service and a product? A service, like healthcare, is a service, while a product, for example, is like a sofa or a mobile phone you're holding in your hand. What is the difference between these two? They told you that healthcare is considered a service, whereas a screwdriver or any manufactured item is a product. A product is something you can measure or count. You can measure it, weigh it, count it, and quantify it. It is something tangible and perceptible, something you can hold, unlike a service. A service is less concrete. It is a combination of skills and expertise which are intangible, cannot be measured, cannot be tested, or cannot be verified. A service may have variation from provider to provider, customer to customer, and from day to day. For example, the medical service I provided you today, you cannot hold it in your hand, right? Or you cannot even feel it, touch it, or even sell it or resell it. It cannot be stocked or stored, unlike products. Once you provide a medical service to someone, it is done. You cannot inventory it, resell it, or quantify it. Unlike a product, of course. And we all agree on this. So now, let's focus here on the details. Let's focus here on Donabedian. The Donabedian model from a scholar named Donabedian said, I want to measure my performance. To measure my performance, I need to create a performance indicators. These indicators to measure the performance. These performance measurement indicators I will divide into indicators specific to structure, indicators specific to process, and indicators specific to outcome. So, to assign an indicator to each of these, I need to know what might fall under structure, what under process, and what under outcome. So he gave examples of structure indicators in the organization. In the healthcare model of Donabedian model, under structure, process, and outcome, he gave examples of structure indicators in the organization. We have the staff, departments, equipment, the supplies, the environment. The departments, the environment you live in, the external structure of the building, the working hours, whether I decide to work for 24 hours, 12 hours, or 8 hours, the medical record, the electronic file, either you want it to be in paper-based or electronic. These are also things related to structure. If you want to give an example specific to a policy, you could use examples like work hours. For instance, the hours of operation are something you measure using structure indicators. When providing healthcare services, we are talking about the factors related to process. Now, process is considered to include any action you perform. This is considered as anything falling under the process category. For example, it takes from when a sample is taken from a patient or the turnaround time until the test results are ready. That is called a process indicator. This includes housekeeping processes, cleaning procedures, nursing care, physician orders, the transportation, and any processes you perform. They all fall under the process category. As for outcome, Outcome can be described as the end result, the final outcome we achieve. For instance, did I achieve something specific or not? These are all considered example. What I mean is, can I perform care without having the right structure? Of course not. I must have the structure to enable me to perform care, implement the processes, and achieve the desired outcome. This is necessary to ensure that without structure, processes, and the right care, we won't achieve the final outcome. This forms the connection between the structure and process to achieve the outcome. Okay, so these are the sample, the meaning of the structure as defined as conditions under which care is provided. The structure measures are the things that must be present to do the work. So example, the equipment, supplies, healthcare professionals. So these are structure. Processes are how the healthcare is carried out, the policies and procedures, the techniques utilized, and so on. And these are clinical processes and care delivery processes, like the recording, writing, administrating, dispensing. And lastly, the outcome is defined as changes, either desirable or undesirable, in individuals and populations that can be attributed to healthcare. The outcomes are the results that come from completing the processes. Example, morbidity and mortality rate, infection rate, and patient satisfaction. All right, up to now, everything is good, right? So we'll now talk about the integrated delivery system, or what we call the IDS. The integration also applies to the information systems, including the common database, tracking over time, profiling, and reporting. What this means, how can I create connections through for the information? By linking it all together. That is, linking the information I have in the system to help me quickly have a database. We call it something like creating integration. We have two types, the horizontal and the vertical integration between us and others who provide the same services we offer. So, if we create integration with someone providing the same services, what benefit will we gain? The benefit is that, for example, if you are an owner and have 4 or 5 hospitals, when a patient goes to hospital A, gets some investigations and tests done, and then goes to hospital B for another checkup or a different specialty, they won't need to repeat the test. If they log into the system, all the tests and everything they had done before will appear, and even their history will be visible. Here, we can create efficiency because we have reduced the need to duplicate or repeat procedures unnecessarily. This is what we call horizontal integration. Okay, so what about vertical integration? They said, if you create integration with someone who provides services that complement yours, for instance, you are a small organization without an MRI or CT scan center, and you sign a contract with another center that offers MRI and CT scans, then there's a contract between you. This is called vertical integration, where the patient's MRI data will automatically appear in your system and be saved in your records. This way, you have achieved vertical integration with someone providing a service that you don't have. So this is called service integration, and it is a systematic way to enhance efficiency. All right, so that concludes today's lecture. It was simple and easy. Do you have any questions so far? Hi, Doc. That ends my lecture.
Excellent. Excellent يا نوبيلا. Really
Oh,
excellent.
thank you.
Can we stop recording?